This mini quality improvement project is upon the safety of laryngectomy and tracheostomy patients in ED resus at Milton Keynes University Hospital. Airway emergencies, we know, will kill a person the fastest. A, B, C, D in every life support course is reiterated time and again. So while this is a rare presentation of a laryngectomy or tracheostomy patient, it's a presentation that if each and every person knows the correct steps to take, in which order, it can potentially save a few lives over the course of a career. This has been backed up by National Tracheostomy Project and global collaboratives and other sources. And this video will present some of that research and background knowledge. The video will also present some of our findings in initial sourcing research, where a knowledge gap was identified amongst staff in our department and an area ripe for quality improvement. Also in this video will be discussed the bedhead signs, a step-by-step approach, an algorithm for approaching these patients, as well as various aspects of associated knowledge. What we hope to do in the future as part of this quality improvement project and possible ideas for further expansion. I hope you enjoy the video and the education in this online arm, which will be supplemented and complemented and has been by several face-to-face and teaching methods as well as simulation. Thank you.
A mini quality improvement project or QIP around tracheostomy and laryngectomy care. On nights in A&E, a few times I've seen potential SUIs where laryngectomy and tracheostomy patients have arrived, and myself and others have sort of known what to do, but sometimes all the equipment hasn't been there and not completely known. And as part of increasing patient safety in this area, this project has been done. Part of that has been this teaching session, where you can see the difference between a tracheostomy and a laryngectomy with anatomical diagrams and teaching. In a tracheostomy, a hole is created into the trachea through an incision in the neck, whereas a laryngectomy is a complete removal of the larynx with the redirection of the trachea. This is a tracheostomy safety bedhead or sign, showing when it was performed, the size and emergency numbers. Here is an algorithm which summarizes the process to follow. The key difference between tracheostomy and laryngectomy being that with a tracheostomy, the patient still has a patent upper airway, potentially, but not with a laryngectomy. If unsure, apply high flow oxygen to both the upper airway and the opening in the neck. There are some diagrams here to help differentiate between a tracheostomy and laryngectomy. If the tracheostomy appears to be patent, then one can proceed oxygenating through that. If it's not patent, one can try to assess removing the speaking valve or the cap and seeing if a suction catheter can be placed. If not this, deflating the cuff, look, listening, feeling at the tracheostomy, and using different methods like waveform capnography to see if air is being passed. If one still cannot pass any air, then one should remove the tracheostomy tube, as at this stage it is an airway obstruction, and if the patient is still not breathing, commence CPR. Otherwise, continuing ABCDE assessment. Here you see it all summarized. Here's a hand ventilation circuit. Speaking valves can get blocked and can be used incorrectly at times too, and may need to be removed in an emergency. Here you see inner cannulas or various types of tracheostomy tube that again can get blocked and may need to be removed if one cannot suction with a fine tip suction catheter through the tracheostomy. Here is a diagram showing removal of the inner cannula, and a diagram showing the soft tip suction catheter to try to determine patency. These are much better to use than bougies that can cause trauma in the local area. This diagram shows a displaced tracheostomy tube and a false passage. Here is a bedhead sign for laryngectomy. You can see there is no patent upper airway. This is the laryngectomy algorithm. Here one applies high flow oxygen. One can assess the patency. Most laryngectomies will not have a tube in situ, but one can remove the stoma cover if present, or an inner tube if present, if one is suspecting that's causing a blockage. Again, one tries to pass a suction catheter, a fine tip suction catheter, and if one can, one proceeds with suction. If not, one needs to deflate the cuff if present, look, listening and feeling, assessing with waveform, capnography, and if the patient is still not stable or improving and there is a tube in situ, it should be removed. And then the ABCD assessment continued if the patient's breathing through the circuit, and if not, and one cannot find a pulse form waveform with waveform capnography, then again CPR must be maintained through, in the case of laryngectomy, the lower airway. The specific differences with previous guidelines with the current guidelines include the prominent early role of waveform capnography, oxygenation being prioritized, and avoiding trials of ventilation via potentially displaced tube. Suctions only attempted after removing a potentially blocked inner tube. Oxygen is applied to both potential airways, and one uses simple methods to oxygenate and ventilate via the stoma and the tube. A blocked or displaced tube should be removed as soon as it is established and not as a last resort. Here, some equipment needed is listed. Humidification equipment, suction with a selection of appropriate suction catheters, spare tracheostomy tubes, the same size, a size smaller as well, a clean pot for spare inner cannulae, sterile water, scissors and a stitch cutter if a tracheostomy tube is sutured, and water-soluble lubricating jelly, a sterile dressing pack, tracheostomy dressings, tapes, PPE, sterile gloves, and, if needed, communication aids. Emergency airway equipment can include the basic equipment, self-inflating bags, oral and nasal airways, and advanced equipment like an LMA, laryngoscopes, and appropriate tubes, capnography, dilators. Airway red flags include, in the tracheostomy or laryngectomy patient on the ward or in A&E, air leaks, bubbles, grunting, snoring, stridor. Breathing flags in an emergency. Red flags can include apnea, detected by capnography or clinically, accessory muscle use, a raised respiratory rate, increased airway pressures, lower tidal volumes, hypoxia, whistling or noisy breathing. And circulation flags include signs like tachycardia, hypotension, and all the normal signs of circulatory dysfunction. Specific tracheostomy red flags can include a visibly displaced tube, and if this is an adjustable flange, one may see where it was last positioned. Bloodstained secretions around the tube. A recently performed or changed tube may bleed a little, but if in doubt, this could be a red flag and should be reported to a senior. A patient reporting increased discomfort or pain, or requiring lots of air to keep a cuff inflated, which could be because the cuff is damaged or has an air leak. One can see here a summary of the red flags A, B, C, tracheostomy in general. E-learning for healthcare has many resources on tracheostomy tubes, as does the National Tracheostomy Project and the Global Tracheostomy Collaborative, for which links I will provide below in the description. I hope this presentation was useful and helps a little bit in the care of these patients, which, along with appropriate e-learning for health modules, SIMS and local teaching, may help further the understanding as one source in the care of these patients, and hopefully as part of this quality improvement project can help the awareness of this area at my NHS Trust, Milton Keynes, and others. Thanks for this local teaching, and again, to finish, we'll just summarize the difference between tracheostomy and laryngectomy. One has a patent upper airway with a tracheostomy, and one does not, and when in doubt, apply oxygen to both areas. Thank you. Thanks so much. Bye.